Okay, the next panel, I just want to quickly introduce this and thank the chair for sort of chairing this panel. And Professor Naveed Sattar, unfortunately, was not well, so he had to pull out. So I sent a text to Andrew Morris yesterday at 4:30, and Andrew has stepped in at the last minute to be able to chair this. So thank you very much, Andrew, for doing this.
Okay, let's kick off. What a fantastic talk from Tony. How do we follow that? But we'll do our best. So I'm Andrew Morris. I'm the Professor of Medicine in Edinburgh. I'm Director of Health Data Research UK. Good to see all the name checks for data today, which I do think is the golden thread. And I'm also President of the Academy of Medical Sciences. So thank you for the text, Munir. I'll get you back. So we've got a terrific hour in front of us because we're going to talk about advances in treatments for obesity and its comorbidities. And secondly, we're going to look ahead, global opportunities and challenges for prevention and population health. I think Mel this morning started with his favorite quote, which was, "Prediction is very helpful, especially if it is about the future." But I've got a slightly better one. Charlie Munger, do you know who Charlie Munger was? He was Warren Buffett's vice chair in a big industrious financier. And he said, "I hope I can find out where I'm going to die because I'll never go there." And actually it worked because he sadly died 4 weeks before his 100th birthday. Wow. So there we go. So okay, so we're going to look to the future of obesity. And I thought what we do is 5 things. So we're going to cover the societal perspective, the patient's perspective, and how do we put the patient at the heart of everything we do. New treatments, because there's been an avalanche, but then look ahead towards prevention of obesity. But most importantly, I think we'll try and keep as much time as possible for questions, because I think try and get a dialogue going. So before we kick off, I'm going to ask the panel to introduce themselves. So we'll start with Simon.
Thanks. I'm Simon Griffin. I'm Professor of General Practice in the University of Cambridge and a jobbing GP. In fact, I should be in surgery at this minute if I hadn't been invited to come here. And I do trials mainly of behavioural and policy interventions, as well as looking after people with diabetes and obesity.
Afternoon, everybody. I'm Rachel Batterham. I currently work for Eli Lilly and Company, which means that I'm not allowed to answer any questions to do with medicines at all. Prior to that, I spent 25 years looking after people with obesity. I led an obesity service and also did obesity research based in London. Thank you.
So, hi, I'm Melanie Davies. I'm a Professor of Diabetes Medicine at the University of Leicester, and I'm an honorary consultant diabetologist. So I work particularly with people living with early onset type 2 diabetes. And I'm also director of our Biomedical Research Centre, and we do a lot of the phase 2 and phase 3 trials of therapies for type 2 diabetes and obesity.
Hi everybody, good afternoon. It's a pleasure to be here. Thank you for the invitation. And it's great that the patient is actually at the heart of everything that you're doing. So thank you, Andrew, and thank you to our previous speakers. My name is Vicki Mooney. I am a patient living with obesity, MASLD, sarcopenic obesity, a number of other NCDs. I am the Executive Director for ECPO, which is the European Coalition for People Living with Obesity, and I'm co-chair of the Global Obesity Patient Alliance. So it's a great pleasure to be here with you all.
Fantastic. Right, so we'll start at the sort of societal level, and I'm going to come to Rachel first. So Rachel, have we successfully transited from a view that obesity is not personal failure, but is a medical condition?
No, not at all. So as you've said already, it's clear now from the science that obesity is a disease. We know it's multifactorial and we know it's chronic. We also know that it leads to at least 200 other complications and premature death. But if you go out into the streets and ask the general public, they view obesity as a personal failing. It's something that the person themselves should take responsibility for. And that view goes into healthcare professionals. Many healthcare professionals stigmatise people with obesity and just focus on personal responsibility. And the media in particular is very bad at portraying that this is willpower and not a disease. And the consequence of that is that people don't get diagnosed. The majority of people living with obesity do not have a diagnosis at all in their medical records. They don't get empathetic treatment that exists, and their health deteriorates. So when we're talking about prevention, actually treating obesity prevents all the other complications that come. And we need to do huge amounts to change the narrative so that obesity is recognised by governments, policymakers, and the public as a disease that's worthy of treatment.
Okay, so who wants to chip in on this one?
So I'm happy. So I think I see that every day in my clinic, where I have a lot of young people living with early onset type 2 who have been incredibly stigmatized by the conversations that they've had with other healthcare professionals. And I think we can make a huge positive impact, but we can also leave a very, very negative impact, which can have implications for people for many decades afterwards. And I think we have a huge responsibility to change that culture.
Okay, so maybe Vicki, I can come to you. You know, how do we harness the power of the patient voice to change this narrative, but also to link to Tony's talk, to put them at the center of the research engine?
So I think the challenge that we have is exactly what Rachel described. Obesity is seen as a lifestyle disease. It is purely your responsibility. Now, if obesity is 40 to 70% genetic, and I have genetic obesity, how is diet and exercise and that lifestyle going to actually impact my own biology? It's not. It's going to give me greater health. Like people say, oh, you've great hair, or you've great nails or skin. I'm like, you want to see my diet. You want to see what I actually put into my body, because I have so many NCDs that I take care of it. So essentially, we need to get past that obesity lifestyle disease, and we actually need to invite the patient community of people with obesity into all conversations as equal partners and stakeholders. Until you do that, you are speaking at them and you're speaking about them without understanding that they are disease experts in their own right. If you look at the clinical profile of myself and my colleague that I work very dearly with, same age, both in menopause, we both have various different, very different, I suppose, NCDs that we've had throughout our lives, diabetes included for myself and for my colleague. The diagnosis for us has never been obesity, as Rachel said. The treatment for us has been completely different, right? And that's because we got personalized treatment. Now, if we didn't get personalized treatment and we weren't in a weight management program, well, then we were just signed off with a GPL1 or for bariatric surgery without realizing that we needed very different treatments. So your patient is actually a tool in your toolbox to utilize. Take their experiences and their voice. They know the challenges that exist out there. They know that affordability, availability, disease recognition is all a barrier to them getting what they need. So speak to them. You know, they're not infectious. You know, you can talk to them. They're well educated. They are not just, you know, low. I think there's this, which really gets me, is that because obesity and socioeconomics, when we look at that lower income demographic of people that is high in obesity rates, there is almost this assumption, and it's fueled by the narrative in society that people with obesity are just stupid and they're lazy and they're sloppy and everything else. My guidance counselor, 15 years old, she said to me, she said, Vicki, she said, you're not visually presentable. In the 80s, they didn't do a school uniform for somebody who was XXL or a size 20. And she said, you're not very academic. Because I sat at the back of the class because I didn't want anyone to see this. And I hid. And she said, so your best option is to go and get a factory job and a local factory. And my very first job was as a glass blower and sheet metal worker. That was my first job. Because I believed what she believed, which was what she's seen. She didn't know my story, and she didn't realize in years to come that I would work at this level doing what I'm doing. The power of the patient voice is instrumental for you to utilize, and it is a tool.
Okay, Simon, do you want to comment on this? If you had been in your clinic today.
If I had been, I'd be running about half an hour late, and there'd be very angry patients asking reception what was going on. I concur with everything that's been said. I mean, they are a truism, the words that you've expressed. Clearly, obesity is not about personal failing, in that the underlying determinants of obesity, so diet, physical activity, energy balance, are habitual and environmentally cued. And so it's not like people are making conscious choices every minute of the day to overconsume highly palatable, low nutritious, energy-dense foods and also be sedentary. So you said, is it a personal failing? Clearly not. But it is a failing of society. So obesity is a societal problem as much or more than a medical problem, in my opinion. If you walk out of here and walk, well, perhaps not in South Kensington, but certainly most places where we live and work, you will be bombarded by energy-dense food advertising or providers or purveyors. You will be bombarded by the opportunity to be sedentary and not to stand, let alone move. And it's very difficult for human beings who are phenotypically, in utero, environmentally patterned to avoid famine, because that's what was going to kill us in the last few million years. It's very hard for those individuals to then have a cognitive process which is exhausting, that means they make what we would regard as the healthy choices every second, every minute of the day. So, of course, we mustn't blame patients, but we must, or people, but we must enable them to make those healthy choices, which I'm afraid goes beyond thinking about a medical solution. So if we're going to have more and more expensive, more and more sophisticated, more and more profit-generating medications, there are essentially more sophisticated fish nets to grab people out of the river just before they go over the Niagara Falls. But we're not looking upstream at the industries that are pushing people into the river in the first place. And if we don't deal with that, we're never going to truly help people who are yet to become obese, because maybe 2/3 of this population will be obese within the next 10 to 20 years. And we're not going to do very much to help the people who are currently living with obesity. The drugs, an enormous, huge development, and I certainly applaud them. And in what has been a litany of failure in terms of medications for people living with obesity, this really is a beacon of hope. But it cannot be our only beacon of hope, because it will bankrupt us and because of the massive increase in inequalities that it's generating. So on that note, I'll probably get off my high horse.
No, you were just getting going. Okay, so we've moved on. This is going to be an optimistic panel, you see. So you said let's touch briefly on the therapeutics, as you talked about a litany of failure. And actually, I looked it up. It was 1982. So that was the first day I walked into medical school at the University of Glasgow. So that was the same year that they cloned the pro-glucagon cDNA from the anglerfish. And if you've never seen the anglerfish, look it up, because it's very ugly. And that identified the GLP-1 sequence. And I remember a guy called Dan Drucker, he was always only given posters, because everyone thought, oh, this won't be important at endocrine meetings. But now it is just mushroomed. So Melanie.
I prefer the Gila monster lizard saliva as the source of GLP-1. I think that paints a nicer image.
There's one in London Zoo if you want to go. Quick trip.
So, a lot of, as Simon said, a lot of excitement around GLP-1. So Melanie, can you just give the audience what your thoughts? You know,
So-
do they work?
Yeah,
How well do they work? How safe are they?
I just want to come back quickly to the point Vicki made around person and public involvement and engagement. So I think in the UK now, in terms of funders, for example, MRC and IHR, you can't get anything funded, and it's absolutely right that you can't do this unless you have a really robust PPI program. So you have to engage, You have to involve, which is working with people, not doing nothing about us without us, which is really important. And often people are participating. When we do our commercial trials, it's very different. The protocols often haven't been discussed with people living with the condition. They're often brought in late. We often suggest that we would like to work with our panels and our community groups to help them improve the design. So there's a real, I think, need for industry to do better in terms of their patient and public involvement. Coming on to the incretin or GLP-1 based therapy, certainly I'm predominantly a diabetologist, and it's completely transformed what has been possible in the clinic. I think I understand where Simon is coming from, but we see many people living with, we have a child with type 2 diabetes at the age of 8 in Leicester. I work in a very multi-ethnic city. We see people coming from all walks of life with type 2 diabetes, but particularly underserved communities. In the past, it's been very difficult to find things that help. We've been driven by trying to improve HbA1c. People gain weight, the medicines don't work long enough. We end up adding medicine after medicine. It's almost an algorithm to failure. And I think what's been absolutely transformative is that you can start medicines like semaglutide or tirzepatide now, where it's almost a relief for patients, because they start to see something that actually starts to make a difference. A1C often comes down to target. They're able to lose some weight. They're then able actually to take on some of the lifestyle measures that have been so difficult before, that often is really helpful for them in terms of their overall quality of life. So I think it has been transformative. I think the issue is, and there's data from the States now, isn't there, showing that the use of these medicines actually widens health inequalities. It's really important that we make these more expensive treatments accessible to the people that need them most, and not just a lottery as to the people that are most articulate or able to afford them, get access to them, because that's just driving health inequalities. But I don't know if I've quite answered your question, but I'll pause there in case others want to come in.
It's not a lottery, because that implies random and the play of chance. It's actually designed currently to increase inequalities. 95% of GLP-1 drugs in December 24 were privately prescribed. Yeah. So obesity is socially patterned. The only effective drug treatments we have are inversely socially patterned.
I think in type 2 diabetes, and I agree with you, even the NICE guidance is interesting in the UK, as contrast to the rest of the world, where the GLP-1s, even though they have, we've got really good data with semaglutide in terms of cardiovascular outcome data, renal outcome data. So for my, when talking to patients, and you're talking about not just the weight management and the A1C, but you're trying to invest in long-term outcomes. These, they're interested in, their children, their grandchildren, their long-term health. We have some of the best data now with incretin-based therapies and the SGLT2s, and yet they're still way down the algorithm from when we can use them.
And at last, we're giving tablets. We've been talking about weight with patients with type 2 diabetes for a long time. And yet many of the drugs we were prescribing actually increased their weight. So sulfonylureas, pioglitazone, and insulin. So it is a complete breath of fresh air that we have a drug that reduces weight and reduces glucose and reduces the actual outcomes we're trying to prevent. Because lowering an HbA1c is neither here nor there to many people, but not having a heart attack is quite important to people.
Yeah, and you mentioned the pipeline. I think we do a lot of the clinical trials, and there are 40, 50, 60 assets coming through and we focus very much on, in diabetes and weight management, in terms of that weight loss efficacy early, but then there's huge discussion in terms of weight maintenance. What do you do if you can't continue these medicines because people can't continue to afford them? How do we look at different combinations? There's real excitement, I think, in terms of GLP-1 as a backbone, whether it's with glucagon, whether it's with PYY, whether it's with GIP, clearly, and the triple agonists coming through, and also the combination with agents that are helping people to improve body composition and maintain lean mass. So the possibilities are almost endless, but how we can make those treatments available to the people that need them most and manage them over the longer term, I think there's still huge numbers of questions there.
And can I just add to that, right? I think probably when we talk about obesity disease recognition, we don't talk about, people hear disease and they go, okay, obesity is a disease. Okay, well, people need weight loss medication. It's about obesity, and weight is a symptom of obesity. And when it comes to obesity, you actually need, it is because it's a chronic recurring disease, and we know, we've seen the signs, we know about weight set point, we know that people come off medication or have bariatric surgery and then there is weight regain. That is your biology. That's not, that you've had, a latte with like every kind of marshmallow and whipped cream and sugar and everything else once in a month. Essentially, it needs lifelong management. And that's the part that we're missing, is that, I'll give you an example, right? If you think of somebody with skin cancer and they have, say, a cancerous mole, they go to their doctor and the mole is removed and they're sent away. Now, the doctor doesn't say, okay, bye now, here's a sun hat and factor 50. You're gone, you're signed off. They don't do that. You go to a doctor and you want to lose weight. You want to manage your obesity. And they see that you've lost a certain amount of weight and that's it, you're signed off. You don't go back to that weight management clinic. And we look at clinics across Europe, and some people are 7 to 8 years waiting to get on that clinic, waiting to get access to the clinic. And then suddenly they reach what the doctor thinks the target weight, and they're dropped from the system. Now, when they get dropped from the system, they end up like myself, which is, I was told, Vicki, you have cirrhosis, years ago. And I said, really? I said, what are you talking about? And he said, we need to do more scans and we need to do a little bit more and we'll send you to this hepatologist. And I said, right. And the last 2 years in Europe, we started working with the liver patient community. We started working with the chronic kidney community, the global heart hub, heart community, and diabetes. And the reason for that is that obesity and all of the cardiorenal metabolic areas are so intertwined and braided together, like a woman's hair plait. And I sit in all of those disease areas, unfortunately. And when I heard that 8 to 9 people with obesity throughout their life will end up with MASH or MASLD, I went to my doctor and I said, you said I have cirrhosis going back a long time ago. I didn't pay any attention. I've worked in advocacy for like 15 years nearly now. I said, is that MASH or MASLD, or is there any signs of that? And he said, I don't know what you're talking about. And I actually had to privately go and have my work done, my bloods and my scans and my liver testing all done privately. And then be told, okay, you're back on a waiting list now. And that waiting list is a different waiting list to my obesity management, which is a different waiting list to sarcopenia, which is a different waiting list to diabetes, and different to mental health. And the cost of inaction on obesity is just astronomical when you think of that. My grandmother died taking 22 medications a day. She had obesity. Clearly, with me having genetic obesity, my mum has genetic obesity, my daughter has. No doubt about it, my grandmother had. 22 medications a day, cervical cancer, she had lymphedema, lipidemia, hyperlipidemia, she had a sleep apnea machine, she had diabetes type 2, she had cardiovascular disease, she had chronic kidney. She was on 22 medications a day and not one intervention for obesity and not one conversation. Now, if we had those conversations at an earlier stage, even with myself, I may not be sitting here with liver disease and every other NCD in that CRM area and space. And that's what we need to do. We need to talk about treating obesity to prevent other NCDs and take away that cost on our health systems that are absolutely, at the moment, they're struggling so bad. And it's like this all across Europe. And then I think you'll move on as well, but you introduce stigma. Weight bias and stigma. Obesity is the most stigmatized disease. And I can tell you, the worst part about it is that when it comes to the healthcare setting, and no disrespect, because we all have internal biases, we all do. but it's really important to learn about your own bias when it comes to obesity. And if you're a clinician or a healthcare professional in any way, shape or form, please check your own bias, because when stigma is in the clinic, the care walks out the door, and that's it. And that's not good enough for the patient.
Okay, so the notion that it's a truncal disease, I think John Bell refers to it as a truncal disease, one of the justifications for our future health. But Rachel, do you want to?
Yeah, I was going to say, sort of, when I was in clinical practice and I'd be seeing patients with BMI of 50, and I'd think, how many times have we missed the opportunity? Because you don't get to a BMI of 50 overnight. It's many, many years. And it seems to be that weight has become a taboo subject. So often, as Vicky's saying, my patients would have gone already they'd be seeing the respiratory physician, they'd be seeing a heart doctor, etc. But nobody would ever have spoken to them, particularly about their obesity. And I think if we think about medical school, medical students don't get taught about obesity. Sort of one of the biggest. Or it's just missed off the medical school curriculum. And if, as Vicki was saying, the healthcare systems are not in place to actually capitalise or manage people with obesity. So we need to look at a whole systems approach. There's the prevention, but then there's the treatment. And when we think about prevention, often I'd be seeing patients and they'd bring their children would be sitting outside, and you'd think, oh, actually, we need to do something with the children because, again, because of the genetic component. So I think there's just so much that can be done, both in terms of environmental, as Simon was saying, thinking about ultra-processed food, physical activity, but then also in terms of every time a person sees a healthcare professional, we should be talking to them about their weight, their blood pressure. And you could argue that, so if you in hospital and you have a myocardial infarction and you've got a high BMI, nobody is likely to talk to you about your obesity. If you're smoking, everybody will talk to you about your smoking. So it's just really changing the conversations to really be far more proactive. And I think part of the problem before was that it's very hard previously to actually have sustainable weight loss. And doctors don't like doing stuff that doesn't work. We like doing stuff that works. So I think now we're in a different sort of paradigm shift where we've actually got evidence-based medicine of programs that work, other things that work. We just need to start using them.
Great.
There was an excellent trial done by a small provincial university to the west of Cambridge called Oxford. And what they did is they got family doctors like myself, when they saw a person living with obesity, to raise the subject and to direct them towards solutions, which was Weight Watchers or Slimming World, behavioural weight management program. Which, in all this talk of drugs, I would remind you that behavioural weight management programs are effective, and in fact their effect lasts much longer than the drugs. So when you stop the behavioural weight management program, still 50% of people are below their starting weight 5 years later, which you certainly can't say about the drugs. So I think smoking, where we used to be with smoking, we now mention it and raise the topic. Although there's good qualitative research that suggests that if you mention it every time the patient comes in about their ingrown toenail, then you produce distance and they won't come back for health promotion. But raising the topic and then signposting people. The problem in primary care is, what do we signpost them to? With the 2-year wait for bariatric physician, our guidelines don't really allow us to prescribe these drugs to people without diabetes. So patients, we're going to signpost them, but they're going to be disappointed.
So you made the point about in terms of the long term and what happens when people stop treatment. And of course, if it was another disease like hypertension or lipid-lowering therapy, we would never say, oh, just take your antihypertensives for a couple of years and then stop and your blood pressure will be normal again. That would be a crazy thing to do. And similarly, I think it doesn't make any sense that clearly we have to have better strategies for weight loss maintenance, and it may not be the same medicines that get you your initial weight loss efficacy, and there may be different approaches, and we need to look at that. But I think it clearly doesn't make sense to say that you're just going to be able to stop these medicines and not expect things to recur.
But it also doesn't make sense to me that you'd invest a large amount of taxpayers' money in the medication, but then you wouldn't have a minimum unit price for alcohol, where the evidence is sort of comparable for benefit. It's just that drugs have randomized controlled trials. public health interventions, you have to rely on much softer, so-called weaker evidence because you can't do randomised controlled trials. But in my view, the evidence is as strong.
But Simon, don't you think, I mean, absolutely, if we lived in this world where all the public health and primary prevention thing, well, no, sure, but have the high, you know, clearly we have to have downstream approaches, and we need to have more effective, cheaper, more accessible treatments. And, you know, we've built on a decade of GLP-1s now, and there are some really very effective and very acceptable to patients in terms of their utility. There are more coming through, lots more coming through the small molecules, and hopefully that will drive down the cost and improve the access. But we need both. We need really good lifestyle support, because patients, we don't know about the impact of these medicines in the long term on physical function, and we focus on weight loss and A1C in the diabetes clinic, but actually we need to be looking at can we, you know, slow down the accelerated aging that people with type 2 diabetes have. But we have to do all of these things. We have to have better medicines. They need to be more accessible, and we need to do the primary prevention. It's not one or the other.
Yeah. And actually, just to add to that, right, and I think there's a fear when speaking to the patients about lifestyle, that, you know, obesity is a disease and it's taken personal responsibility away. It's not. Lifestyle is so imperative and it's so important, because lifestyle is about your health, right? And if you have one chronic disease that is a gateway to over 230 other disease areas, well then lifestyle intervention is really valid and important. And I think when it comes to patients, people think, oh, if we actually talk about lifestyle and say, oh, we don't have to worry about that. It's like, no, you have to. That is key for us. Please keep it included. But also when you talk about prevention, please don't just say eat less and move more. A lot of people with obesity have mobility challenges. And people look at me and say, oh, you look great. You've lost so much weight. It's fantastic. And I'm like, you didn't realize that I lost like 70% muscle. And I couldn't climb stairs for like 2 years, 3 years. I went around a mobility scooter and a walking stick. It was a glittery one, though. It was like pretty cool. But essentially, people actually don't see that all of those mobility challenges. And that is why lifestyle intervention is important, and getting access to that physiotherapist that says, right, well, here are chair exercises. Here are things that you can do that you wouldn't have known, and you won't get that information anywhere else. So it is really key as well for us. Thank you, Melanie.
I'm curious around this issue, especially with the GLP-1s on musculoskeletal health and sarcopenia. And just to echo Vicki, you know, coming from Scotland, I play golf.
That's a surprise.
A good walk ruined.
A good walk ruined. So, and I played with a guy, I hadn't seen him for a year, and he came, he'd lost about 3 or 4 stones, and he was on a GLP-1, but he hit the ball 50 yards shorter. Yeah. Well, I was very happy, Trevor. But it's sarcopenia. So what's the current evidence base around that?
So look, I'm sure Rachel and others may come through, but just it's important to remember that however you lose weight, whether it's through bariatric surgery, whether it's through lifestyle intervention, or indeed with the medicines, with the GLP-1 based medicines, you will lose lean mass. If anything, actually, the reassuring thing is if you look at patient-related outcome measures in terms of people's function, whether that's assessed by objective or subjective measures, they tend to improve. So in the heart failure trials, in the preserved ejection fraction heart failure trials, people's function and 6-minute walk test improve. So objectively, physical function seems to improve. However, we know that you lose lean mass. How we measure that and how we assess that is debatable, because clearly also there's fat in the muscle, and so it's important. It's the muscle quality that's important, not so much the mass that may be important. There's some evidence, I think, with some of the agents that actually, if anything, the body composition changes are not as detrimental as some of the other lifestyle interventions, but clearly it is an area that we need to look at, because some of our population, for example, postmenopausal women, South Asian ladies, already start with a lower lean mass. So there may be particular groups that are at risk. We're doing a lot of work in Leicester around that drug lifestyle intervention access. We have big physical activity group, so looking at the combination of resistance exercise, arm ergometry in people that are not particularly mobile, And also, as you know, there's a plethora of new therapies, anti-activin, anti-myostatin, that are looking in combination with these agents actually to help preserve lean mass. So I think it's a really exciting and important area.
It's not just muscle, it's bone, of course.
Yeah.
Yeah. Yeah.
So it's good to have some resistance work. I am slightly worried about these drugs that you mentioned that sound expensive to treat the side effects of the expensive drug.
Well, I'm not sure.
So I
I'm
like
not
the
sure-
ergometer.
I'm not sure there is a side effects of expensive drugs. I mean, it's a side effect of losing weight if you're so I think, you know, and I think actually we need to remember that there was conversations about the aging population. We do have increasingly frail population, but also if I look at the people that I'm privileged to care for in our early onset clinic who are in their 20s and 30s, and we've done a study looking at 1,400 people where we've measured their physical function. We know that if the younger you are, the actual difference, relative difference to somebody of your age without diabetes is about 15 or 20 years. We've shown that these people in their mid-60s are similarly functionally to people in their 90s. So it is really important that we get this right.
Okay, so we're going to have 2 minutes on prevention, and then we're going to come to the audience for questions. So get your questions.
Can I add one comment before you do that? I think it really makes you think that we have to really think it not just about weight, but body composition. And I was part of the Lancet Commission that's just sort of done the new diagnosis of obesity. And that's really saying that we can't just look at BMI, because that's how at the moment we use, but we really need to be looking at simple measures, even waist to height ratio, which NICE brought in, and just get away from just the numbers on the scales and start to do body composition. The pushback is always, well, it's expensive. But BIA is not that bad. And also looking at tech, to sort of, everybody has a smartphone. So when we were trying to think what could we suggest that could be used in India or anywhere, then actually starting to look at tech and looking at body composition using AI and apps is kind of where we need to go and just get away from thinking about BMI.
Very blunt instrument.
So now you can go to prevention.
Now we'll go to prevention. But, so for our guests from abroad, we have a very energetic health minister who says we're going to solve the health of the nation by going from hospital to community, from analog to digital, and from treatment to prevention. It was the same 30 years ago when we had a... But it's still a very useful framing. So one would think that obesity would be a prime candidate in this frame. And indeed, you know, with my academy hat on, we published Health of the Public Report 2040, which was around precision public health, which was about doing the societal sort of geopolitical things around alcohol, tobacco, salt, and highly processed food, but then having precision public health by thinking about the individual. So can I ask the panel, if we were to look forward in terms of prevention, what would be the key priorities in the framing of obesity? Simon.
Oh, right. So whenever I think about prevention, I think of the sort of spectrum from individual through to societal. And I think the danger is at the moment, most of our administrations are veering more towards individualistic approaches and more right-wing rather than more socialist principles of, or even going back to the sort of Quaker type approach where you were looking after your workforce and trying to have a healthy workforce. So clearly there's not an appetite to take on big food nor big alcohol. If you look at the lobbies in Parliament, people like the Portman Group, very influential, and those of us who argue for things like minimum unit price for alcohol have a very weak voice, whereas the Portman Group has a very strong voice. And of course, the MPs spend a lot of time in the Westminster Bar, and so they're very heavily influenced by that. I think we need to work with providers like supermarkets. To try and get them thinking in terms of sailing and getting a profit from health. And so at the moment, they get a bigger profit from ill health. So all the high salt, energy dense, high fat products are in the buy one, get one free. They're at eye level or they're at the checkout. And I think one of the ways that we might change that, if government aren't going to, because they don't seem to be wanting to do that, is having much more groundswell of bottom-up people power type approaches. And having people, there are examples of this in obviously places like California, of farmers markets being the place you go to get your food rather than the industry-sponsored delicatessens, etc. So that would be societal. But like you say, I think you can bring some precision public health to bear on that. So as Tony said in his talk, you go a couple of stops on the central line and you lose a few years of life expectancy. And one of the challenges is that's generational. Because the oocytes that produce the baby were made by the grandmother. And if the grandmother is in the sort of situations that you've been describing, that means what chance does the grandchild have for their whole life? Because they're already programmed to have a much higher chance of obesity. So prevention needs to have a very multi-generational long-term view, which of course government never does. But if we could target our public health prevention, then we should target at the periods of maximum growth. And so that would be women who are yet to become pregnant, women who are pregnant the first year of life. So it's the 100 years, 1,000 days type approach. That would be a more precision approach. So, the government getting rid of child support and getting rid of early support for mothers with children, it was a disaster in my view. We don't have health visitors anymore. Again, that's been a disaster in my view. So we can have precision public health geographically. We can have precision public health for the underlying drivers of diet and physical activity, which vary locally. The problem is that the public health doctors have been moved into the local authorities, and the local authorities have no budget. So when the public health doctor makes these proposals, they have no money to spend. Going right down from the societal to the individual, we can get much better at understanding the different drivers of these behaviours at the individual level. So understanding more about appetitive traits, for example. So the behavioural intervention should be much more focused and adapted to people's individual appetitive traits, which is a bit like the behavioural level of the epigenome that we heard talked about earlier. So there's two examples from the societal down to the individual.
Okay. Now I'm keen, any other burning, because I'm keen to get to the audience, because I'm sure we've got some great questions out there.
I just want to add something to that, right? And I love what you actually said there, and I really appreciate it, because actually in the audience is my colleague Ken Clare, and Melanie had mentioned about PPI and the importance of that work. And he is the kind of person that has worked for 20 plus years in this area to ensure that we're having proper prevention in place. That hasn't actually happened, but hopefully will. But when we talk about a prevention, we're talking about women and childbirth, and like I look at my own daughter who has genetic obesity, and obviously she's been back and forth for checks. She has PCOS as well, right? She's 18 years old, so she is in the healthcare system. And then she, when in time, and hopefully in time she will, go and get married and have children. She'll be in the health system and she'll have checks done. And there's these constant checks with women and screening for obviously, cervical cancer and everything else, right? What about the men? Where are you guys in the clinics? You're not there. You're actually left off. So essentially the men aren't actually screened at a younger age. And when we talk about prevention, we're actually leaving out the guys. So we really need to actually take that on board and say, why aren't we getting men in clinic earlier to actually be screened? And if you think about it and you talk about men think it's okay to go, oh look, he's carrying a bit of weight. Oh, you put on 10 pounds. You must have had a great big dinner last night, a great steak. And that is stigma. That is not right, and that's not okay. And how long does it take for a man to go to a clinic? He must be like losing an arm almost to actually get into the clinic. So, I mean, we really need to address that as well when it comes to prevention, not leave the men off.
Okay, I'm all for that. So, any questions or comments? So we're going to have lots. And actually, we're going to go right to the back first. Hakeem. Very quickly source a mic. And say who you are, because then we get to know.
My name's Hakim Yadi. I had a question based on this brilliant discussion, thank you, on data, which a lot of people have been talking about today. And when we think about data, we often think about the use of health data. But actually, in the context of this discussion, we need to think about other private sector data sets, civic data sets, to make the data actionable to drive outcomes. So Simon, you mentioned supermarkets. Tesco Club Card data could be as valuable here as health data. What initiatives, opportunities are we seeing to bring civic, private and health data together to get a better understanding of how we treat the individual?
Well, I'm chairing. I shouldn't answer.
Oh, come on, Andrew.
So,
Just to give you an example of the data, one of my colleagues, Tom Burgoyne, is a health geographer, and he does all the mapping of fast food outlets. And we did a lovely study in the BMJ showing that your exposure to fast food outlets, so between your home and work, not that you go into, just your exposure to them, correlated perfectly with your fast food consumption and with your level of obesity. And so he now provides a tool for local authorities to look at the density of fast food outlets, look at where they are, and whenever a new planning application comes in, they've got much more power and data in order to inform those decisions about not letting, not having another fast chicken shop in an area, particularly near schools, for example. So, but we're way behind Scandinavia in this. I mean, Scandinavia, some of my colleagues there know the sort of inside leg measurement of everybody in Denmark. And then they're much happier to share that sort of information, which is good for research, but is also good for public health policy.
Yeah,
now to the data person.
I was going to build on that in terms of, so we in Leicester, we have the Space Centre and a huge interest in access, so they can map and look at green space, but also air pollution. And also there are, clearly if you can't access green space or you're exposed to air pollution as well, that also plays in. So I think there are, even beyond the supermarkets, there's quite a lot of environmental data, active transport, other things that could really help us build that knowledge of communities to help facilitate better primary prevention.
One of my colleagues had a Tesco club card, and he used to buy nappy bags from Tesco's. And so they kept sending him vouchers for nappies because he wasn't buying his nappies there, and they assumed he was getting them somewhere else. He bought those bags to collect his dog poo when he went for a dog walk. So it's not always perfect.
yeah, but I think it's a good question, because I'm a big fan of metrology, which is the science of measurement. And a lot of the variables in this space which are of relevance do not sit in the NHS.
Yeah.
So assembling trustworthy data ecosystems that allows, the second point is about the power of linkage of data, because Tesco data itself is of some value, but the real power is when you link it, because then you have exposure. It's classical epidemiology, exposure and outcome. So thinking through how we, in a trustworthy way, we can surface and link data either from the phone, wearables, sensors, or industry is going to be important. Right, any other questions? So I got a lady here. Say who you are again.
Yeah. So my name's, sorry, it's very loud. My name's Shirley, and I work in a digital health company, but I come from the business side. So please excuse my naivety in this question. And it's about GLP-1 usage and rather than misusage. So especially because we work with young people, and on social media there's currently quite a lot on body image, and GLP-1 has become this main drug to lose weight, to look great, and the age just become younger and younger. And I just wonder, we talk about this obesity, but what about, do you have concerns in this younger and healthy group that are using this drug at a very young age? Thank you.
What a good question. Who wants to take that one?
It's one of the things that Lilly are really strong on, that these medicines are for people with the disease of obesity. If you're going to start them, you should be thinking of taking them for your entire life. And we really go against cosmetic use. We had an advert that went out with the Oscars, not this year, the year before, just really saying this is not for cosmetic use. Nobody should ever take a medicine that's not prescribed for the disease that it's meant for. But it's getting that message across.
It's the Wild West out there, let me tell you.
It is, and I think there's some data, isn't there, around about 1,000 people in the UK having through licensed clinics and about 1 million people who are accessing. And I think the danger is the social media messages and the ease with which people can seem to get access by not telling, well, clearly not being open with and also I think access increasingly through beauticians, it is just a real shame, actually, because in the clinic we have so many people that would really benefit from these treatments who can't access them, and yet and also because they're not being used in the way that they should be prescribed. I think under specialist and primary care supervision, they're incredibly effective, but if not, they can be a problem.
So this is where sort of 2 weeks ago I took part in an event in Canada where we were actually working with social media influencers. So we had 50 sort of TikTok specialists in the room, and we were talking about obesity as a disease and the dangers of actually taking them when people shouldn't take them. And I think maybe we need to think about going that route, because my children don't read a newspaper or watch the news. They scroll through TikTok. So it's kind of getting the message across, I think, through the right
medium
audience. But also, these healthcare professionals should have an ethical standard, because somebody's prescribing.
But you prescribe it to the wife, and then one dose a month she gives to her husband.
To her husband, yeah. And they share it. And it's so common. We see it in the support groups all the time. And you have the conversation where somebody's saying, well, actually, my sister was over, so I shared my dose with her, and she's doing better than I'm doing. But you know what? I'm feeling weakness, but I'm taking 75 grams of protein in one go. And I'm like, how on earth are you taking 75 grams of protein in one go? How does that happen? Oh, well, I seen this influencer online. And it's like, where are you actually getting your prescription? Oh, I bought it from the beautician. And this is so unbelievably common. And that is another big challenge.
Okay, we've got time for another question. Great. How about...
One there.
The mic's close. Lady at the back.
Hi, Jackie Sanders. I'm interested if we take it back to the patient, and Vicki, you talked very eloquently about your comorbid conditions and the number of waiting lists that you have to go through to get your treatment for the individual comorbid conditions. That seems to be something that we're not looking at enough in terms of how do we make the whole pathway and experience for people living with obesity a better experience, connecting their treatments, connecting their data, connecting the doctors that are looking after them, so that it's much more of a team effort and consistent over a long term. I'm just interested if there's anything that people have seen that is working in that area.
So we actually, I was going to say, we haven't seen anything like that working. I think if you take the example of the multidisciplinary team that we have in the weight management clinics, that needs to broaden out to, and something that we're working on at the moment. And I'll give you a prime example. We were actually in Parliament yesterday over in Brussels, where you guys don't come anymore, sorry. But essentially we're there yesterday, and we're there with the liver patients community, we're there with Global Heart Hub, we're there with European Kidney Patients Association and IDF, the International Diabetes Federation. And we're talking about all of these disease areas in the CRM area. And the conversation came up, and I said, why don't we actually have, on top of the EU cardiovascular plan, actually CRM screening? Why can't people actually be screened for those connected diseases altogether? And it's not a siloed approach of we're going to here and then we're throwing you in a waiting list there and it's costing an X amount to the system here. So we've actually discussed that, and we're bringing it to a parliamentary event that we're having at the end of the year to really push that with the European cardiovascular plan, because essentially obesity is not going to get the disease recognition that it needs on its own. So we're just going to fly into coattails of cardiovascular and utilise that, because how many of our patients go to their cardiologist after an incident and then is told, you need to lose a few pounds.
Okay, so time for, I'm keen to get as many questions in. So gentleman there, then a gentleman there.
Hi, I'm Henry from Leicester. I just wondered, at what point do you think innovation in society can conflate and actually impact obesity? I see it time and again in discussions and panels that the focus is often on food and big alcohol and things. What role do you think, for example, TikTok and the convenience that we now have in society to be able to spend our entire days on our phone has an impact on obesity itself?
I think everyone's nodding vigorously.
clearly, the more time you spend sedentary, receiving information from very powerful industry in terms of the adverts, the more your behaviour is likely to move in the wrong direction. I have this slightly quaint view, and that is the health of our population is intimately linked to the health of the planet. So if actually we ate locally sourced seasonal food, then the planet would be better off and we'd be better off. If we actually walked to work, walked to our social environment rather than drove, the planet would be better off and we'd be better off. So your solution about technology, in many ways, the sorts of things I'm describing are the reverse of technology. It's going back and doing things that we used to do.
Okay. And then I think we're up for time. Is that right? Coffee's waiting. So final question here.
Very quick. I'm Michael Browning from the small provincial town of Oxford. And I guess I'm not an expert in this area, but for GLP-1s, every week there's an amazing trial showing that it improves outcome in one area or the other. Yep. And you've just mentioned that almost everyone in the world is buying it privately, so they can obviously see a value of this treatment that is not reflected in its licensed indication. So do you think the indication, at least in the UK, is driven by money, and because of that, some of these problems are being created? By money, I mean it's too expensive for society to pay for it.
So it's not quite right, is it? Because the licensed indications actually do reflect those outcomes. I think it's more in terms of how, if you look at the NICE guidance for tirzepatide, I think they've actually made the case that it is cost effective for quite a broad group of people, but what the difference is the implementation plan to implement that into the NHS is going to take, I think, 9 years.
12.
12 years. So I think there's this disconnect between the licensed indications for the medicines, which have increasingly, as you said, very high quality outcome data, which if we were to communicate that to people would absolutely, but then that gap between what's affordable and what's implementable within the current NHS.
Okay.
Thank you.
So I was going to try and summarize that, but we've been... What a wide-ranging discussion, and I hope you all agree. What a wonderful panel. So can you give them all a round of applause?
Thank you.